prepare to listen to Carissa's healthcare presentation. I'd like to introduce Carissa McLaughlin. She's with AWC, Employee Benefit Coordinator, and she is going to give us information. There's a lot of information in the handout that you received that she'll talk you through today about changes coming to the healthcare system. But as you know, our current Health First plan will terminate at the end of this year, and we'll be moving to another Health First plan with AWC. But the benefit coverages are changing, and in some ways that aren't as apparent as just the deductible. So we want to make sure that you're well informed about that. After the presentation, Carissa has generously offered to spend some time here, and if you would like to speak to her one-on-one, we have a sign-up sheet on the desk. Just put your name on there so that we can see how many folks that might be and try to, arrange the time so that we don't, have her here all day and all night, or maybe there's just a few people and we can have a little bit longer conversations. So if you want to do that, you don't have to do it right now, but as you get through this presentation and something occurs to you, you might want to talk to her about, put your name on that list, okay? And with that, thanks to Janet Quinn, who's helped out so much with this and ordered all the delicious food and set it all up, and Kelly and everybody who participated putting the luncheon together. I appreciate it very much. Thank you so much. Looks good. And now I'll give it over to Carissa to finish the presentation.
Thank you. So thanks so much to Joanne and Janet and the entire benefit committee. I've been out here once before, so this might be a recap for some of you. But today, primarily, we are just educating you on kind of what some of those expected changes are for 1/1/18. Some of the plans that you're currently offering will no longer be available, so they've asked me to kind of highlight some specific areas that we can go through and review together. If you have any questions at any time, is this better? Okay. So if you have any questions at all during the presentation, feel free to stop me. I am going to repeat them because this is being recorded, so we want to make sure that folks viewing the recording can hear the question as well as the answer. And like I said, if you have anything that you don't want to discuss in front of the whole group, you can absolutely come meet with me afterwards, and I'm happy to walk through more specific scenarios. Okay, that works for me. Thank you. So on that next page, you're going to see some of the options available for 2017, which will highlight that those two $10 copay plans, so one on the Kaiser side of things and one on the Regent side, are being eliminated at the end of this year. We'll talk a little bit about why those are being eliminated and let you have questions on those if you do. One thing to add is that I did not include on here the two high deductible health plans. So there's a high deductible health plan on Regents as well as Kaiser, and we'll be talking about those as well today. And I did not include them on this slide. One thing to keep in mind is really the key differences here are the networks. So it's the same as you have now, so you already offer Regents and Kaiser, but essentially the Regents plans are a PPO plan, so a preferred provider organization. So what this means is it's a little more self-managed care. For example, if you think you want to go to a dermatologist, you can self-refer to a dermatologist. On the Kaiser side of things, so this is formerly Group Health, it is an HMO plan, which means you do need to go to your primary care physician and obtain a referral to go to that neurologist. You can't just refer yourself for most services. The exception to this, of course, is the Kaiser Access PPO plan, which does offer some of that self-referral power, but within the Kaiser network. So this specific plan, that Access PPO, it's a $250 deductible plan, but it utilizes not only those typical Kaiser or group health facilities, but also the First Choice Health Network. So you do have a more broad selection of doctors to choose from, but you do get a little bit of a discount if you keep it in-house and go to those group health or Kaiser facilities. So the first thing we're going to talk about is the elimination of these $10 copay plans. So the primary reason that we're eliminating these was in preparation for the excise tax or Cadillac tax that's expected to be implemented as part of the Affordable Care Act. So originally this was expected to go in 2018, so January 1st of 2018, which is why we opted to remove these plans on this date. It has since been delayed until 2020, so currently that's when it's expected to hit. What this tax will do is essentially the federal government sets a level of what it determines to be a threshold for medical plans. And if you have a plan that's above that threshold, any amount over it is taxed at 40%. So these $10 copay plans would have been above that threshold immediately had it gone in place in 2018. A 40% tax is significant, so as much as AWC loves to kind of eat those nickel and dime costs that come down from the carrier sometimes, a 40% tax is not something we would be able to absorb. So we would pass that along to the cities. The cities would likely not be able to afford it either, so they would likely pass it on to employees, and if you're paying an extra 40% on your medical insurance, you're likely not going to want to be on those plans either. So when this was delayed, we did consider delaying our removal of these plans, and our Board of Trustees opted not to. The primary reason for this is we really needed to allow adequate time for groups to negotiate off of these plans. A lot of our groups, specifically unionized teams, do negotiate on a 2 or 3 year cycle. At the time that it was voted to delay the excise tax, many of our groups had already moved off of these. So we did decide to just stay the course, and the other primary reason for that decision is just the non-affordability. So we have heard from many of our cities, towns, and non-city entities that these plans are just no longer affordable for them to continue to offer. So you'll see at the bottom of these pages that Regions $10 copay plan is about $750 a month for just the employee, and $2,200 for a family of 4. The Kaiser options are a little bit cheaper, but still expensive at $610 for just the employee and about $1,800 for a family of 4. So those are very expensive plans. You will see as we go through that those other offerings are a little bit less expensive, but not tremendously so. But you will see some greater cost sharing in some areas, so it's just important that you understand these as we go through it. So this is just a little information on kind of the method to the madness behind the excise tax. So essentially, the idea here with this tax is that if an employee has a higher out-of-pocket cost when they go to seek services, so not a whole lot higher, but essentially if you feel like you're spending your own money when you go to seek services, then you're going to be more cautious about how you're using the services. So you're going to seek services when it's appropriate for you at an appropriate location. By doing so, it keeps the healthcare costs down, which lowers costs for the employers and lowers the cost for you as the employee. So whether or not we agree with that, that's just kind of the mentality behind these tax. One thing to also point out, no one has raised their hand yet, but maybe because I haven't taken a breath. Essentially, the Affordable Care Act is obviously a hot topic with the current administration, so they've made it very clear that the intention is to repeal and replace. In the replacement plan, there is expected to be a very similar tax, so it's not called an excise tax, but it's called something else, and it's expected to go kind of straight to the employee level. As you know, that plan is currently, well, as you may or may not know, I suppose, that plan's currently with the Senate. It's going through a ton of edits. It's not going to be voted on until after the holiday, so we'll see what shakes out, but either way, we are expecting a big tax to come in. If it doesn't, we'll absolutely look at revisiting this, but we do expect it either way. Any questions before I move on? Okay. So this next page is just some key terms that you want to be familiar with as we go forward. So at the federal level, really the goal currently is they want you to become more familiar with how your benefits work so that you can be a more active, engaged consumer when using your services. They no longer want you to just say, oh, my medical plan is excellent and I never pay anything. They want you to know what the services cost so that you can help identify if it's an appropriate service for you at that time. So first, a deductible. So this is a specified amount of money that the insured must pay before an insurance company will pay a claim. So this works the same way as your car insurance. So for example, if you get in an accident, you have to pay your deductible, which is typically, $500, $1,000, and then your insurance will start to pay the rest. It works the same with health insurance. So for example, if you have a $500 deductible on your medical plan, typically you must pay that $500 before the plan will start paying at its normal rates. A copay and a coinsurance are terms that you'll hear me speak about today. So a copay is essentially a flat amount that a patient would pay for a covered service. It's typically paid prior to the services occurring. A coinsurance is a percentage rate, so that's really the big difference, if it's a flat rate or a percentage rate. And the coinsurance is often collected after the services have already been rendered. And then the out-of-pocket maximum is the highest amount you would have to pay for covered services in a plan year. So essentially this, on our plans, this includes every dollar you spend toward covered services. So the out-of-pocket maximum would include your deductible amount. It would include every copay, every coinsurance, every dollar you spend toward covered services would be included in that out-of-pocket maximum amount. What's the plan year? When does that start? Okay, so the question is, what is a plan year? A plan year for us is a calendar year, so January 1st through December 31st. So once you reach that out-of-pocket maximum, which is rare, but if you were to reach that out-of-pocket maximum, then the plan would pay at 100% for you for the rest of the year for all covered services. So for example, if you hit that out-of-pocket maximum, it caps what you spend. So you would no longer spend any copays, any coinsurance. Essentially, covered services would be free for you for the rest of the year. Any questions on those before we move on? So this next page is the medical plan monthly rates for 2017. So every year medical rates do typically go up. In August we should be able to provide a ballpark to what we expect them to be for 2018. But currently this is what our monthly rates are now. So as you'll see, that current Health First, the $10 copay plan, that's $752. That next best plan that it sounds like you'll be offering next year is $684. So again, not a tremendous drop, about $70, but you will see some changes to the way the coverage aligns. The high deductible health plan, and there's one on each, is a more significant drop, so about $450 for each carrier per month. And again, these rates are just employee only. So they're kind of all over the board, but we wanted to make sure that you understand that it's a tiered rating structure. So for example, the rate for the employee, the spouse, the first child, and the second child is all a different amount. So you would either add that up in whatever scenario makes sense for you and your family, and then Kenmore would pay a certain percentage, I'm assuming, of those rates. So here is a big factor that Joanne and Janet asked me to hit on today, because it is a big change. It doesn't impact a ton of people typically, but this is definitely a change that you want to be aware of. So if you look at the grid, the two $10 copay plans are coordination of benefits provisions. These others are maintenance of benefits provisions. So let me just kind of explain what these are. So just to recap, remaining in 2018, it will only be maintenance of benefits. So you can no longer enroll on a plan that has a coordination of benefits provision. So this only matters when the plans are secondary. So for example, your employer-sponsored insurance will always be primary for you. So this plan will always be primary for you as employees. If you have a spouse who has their own employer-sponsored insurance and you also cover them on this AWC plan, this plan would be secondary for them. If you have a child, this plan may be secondary for them, and we'll kind of talk about that in a moment. So the difference here, and we have these defined because this is going to be important for you to go back as an individual and look at later, potentially with a spouse, especially if you each have health insurance that you could potentially be covered on. So a coordination of benefits plan, again, these only matter when the plans are secondary. And on a coordination of benefits plan, the unpaid balance is usually paid to the limit of its responsibility. So benefits are coordinated among the multiple health plans to make sure that not over 100% of the services are paid. But for example, if the primary plan pays 70%, a coordination of benefits plan that's say also paid 70%, it would just pick up the rest. So it's coordinating here to make sure that you're not getting 140% of the services and essentially getting paid to get services. but it would pick up the rest, so you'd no longer see a bill. That's really not what the goal is anymore. They want you to see a bill. They want you to understand what your services cost. So again, you can become a more active consumer to see if those services are appropriate for your situation. What a maintenance of benefits plan does is, again, if it's the secondary plan, it will make sure that you're maintaining the benefit level that you would have if the plan were primary, but it will no longer just pick up the rest. So again, for example, if that primary plan pays 70%, and this AWC plan as your secondary would have paid 90, it'll give you the 20% to get you to 90, but you'll still have that 10% patient responsibility left over. So there will no longer just be picking up the rest and you don't see a bill. You will be seeing a bill either way. So based on these changes, if either you as the employee or your spouse or your children are double covered, you want to review the two plans and confirm that it's worthwhile for you to continue double covering them. And many plans have already changed to maintenance of benefits. Regents has told us that they don't expect many to remain in the next 2 or 3 years. So this is something that the insurance companies are doing quietly, so you may want to check on, if you do have 2 plans, what your other plan is doing as well. So the tough thing about this is that we don't have visibility into what that other plan is, or what you pay to be covered on either of the options or any of the options. So we have put together some tips for how you can kind of figure out if it's worthwhile for you or not. So the first one is determining which plan is going to be the primary medical insurance. So as I mentioned, employer-sponsored insurance is always primary for the employee. So if you're employed and you have health insurance for your work, that's always going to be the primary plan for you. If your spouse has insurance through their work, that plan is always going to be primary for them. If the spouse doesn't have employer-sponsored insurance at all, or if they have opted out of the coverage through their employer, then this would be primary. So again, it's only if you're enrolled on 2 plans. If you choose not to enroll on one plan, then it's whichever one you choose to stay on is going to be your primary. When you're double covering a child, it gets a little weird. So the medical plan who belongs to the parent whose birthday falls earlier in the calendar year is the plan that's primary. So for example, if mom's birthday is in February and dad's birthday is in March, mom's insurance is going to be primary. So it doesn't matter if dad is 10 years older, it's whoever's birthday falls earlier in the calendar year, that's who's going to be the primary insurance. So step 1 is just kind of figuring out in your situation which insurance is primary and which would be secondary. Step 2 is comparing the cost of enrollment on each plan. So typically, dependents are more expensive to cover on your medical plan than you are as an employee, or your spouse is as an employee on their plan, as employers typically heavily discount the cost of the premiums as a benefit to you as their staff member. The quality of a medical plan is not determined by the cost or by the cost to you, so it is really important that you look at the cost, but it shouldn't be the primary factor. So for example, here I've included the rates for the Health First 250 after the Well City discount, which does get passed along to you here. But for example, a spouse, the cost is $676. You as an employee pay 10% of that, so $67.67. Child 1, you pay $33.34. Child 2, you pay $27.56. So altogether, you're paying roughly $110, $120. Yes. It caps at that family of 4 rate. Yeah. So then, essentially, here, it's not tremendously expensive for you to cover dependents. However, maybe you have an option that's more affordable for, maybe a lesser benefit. So again, just looking at what those costs are to cover on one plan versus the other is an important thing to consider. Tip 3 is to compare the benefit levels using what's called an SBC, or a Summary of Benefits and Coverage. So this is a document that's a template required by the Affordable Care Act. So every plan has to create a document in this exact template. It looks like this with the blue headings on it. So essentially what you do, the intention of this is that it's easy to read and kind of line up line by line to see how the two plans can compare. So if you get the SBC documents for the AWC plans either from your HR or from us at the trust, and then get your spouse's documents from them, you can just essentially go through line by line and look to see where those gaps are. Some of them are not going to line up perfectly. Every plan is designed a little bit differently, so sometimes it is a little bit more unclear. You can always call us at the trust to kind of clarify that type of thing, or you can call your spouse's insurer to kind of compare, but this should be a really good start, just obtaining those SBCs and looking at those. And then finally, we just recommend that you crunch the numbers, assess your family's medical needs, and then make the decision that's best for you. So insurance is kind of there for when you need it. You don't necessarily think you're going to have a hospitalization this year. You don't think you're going to have a surgery, or you don't think that you'll need to go to the chiropractor, anything like that. Some things you can plan for. So if you know that someone in your family has a chronic illness, or some more minor medical needs that are ongoing. But everyone gets sick sometimes, and it's really, no one can make that decision about what plan is better for you except for you. Do you want to spend more money? Do you want to be on the best plan? Do you want to save money and be on something that may not cover as much and kind of risk that you'll have a higher out-of-pocket cost should you have something unexpected occur? Those are all very personal decisions that are all up to you to make yourselves. You will be hard-pressed to find someone that will advise you and say, this plan is what you should be on, because we just don't know. So we're happy to walk you through and figure out what those gaps are if you have the two different plans, and if you want to send them to me, I'm happy to kind of take a quick glance and tell you where some of those differences may be. But this is a very important thing to look into as more and more plans are moving to this maintenance of benefits provision. Any questions on this? I know it's very complex. Yes, so if the secondary insurance covers at a lesser rate or even the same rate, so for example, if the primary insurance pays 90%, say you and your spouse both work here, City of Kenmore. So you're both on a plan that pays 90%. So primary plan pays 90%, your secondary, which also pays 90%, since you already got the 90%, it's not going to pay anything. Or if your secondary paid 80%, something less, your primary would pay the 90, and your secondary would pay nothing, because you've already gotten more than what it would have given you. So again, it's just very case by case if it's worthwhile to continue double covering. And it's very much a change of attitude, because this is how it always has been in the past. Essentially, if you had the opportunity to be double covered, it was typically worthwhile, and that is just no longer the case in many situations. So moving on to the deductible. So again, we already defined this, but just to reiterate, essentially this is the amount that you typically have to pay before the plan will start to pay at its normal rates. So on the Health First two, so let's start with the high deductible health plans. So on both of these, the Regents High Deductible Health Plan and the Kaiser High Deductible Health Plan, the family benefit must be met before the benefits are paid. So these high deductible health plans work like most typical health plans that are out there. So if you're covering more than just yourself, you have to meet the family level deductible before the plan will pay. If you're only covering yourself as an individual, you only have to meet the individual amount. But if you're covering yourself and your spouse, or yourself and one child, you do have to meet those family level rates before the plan will begin to pay. On the other plans, so the remaining Health First 250, the Kaiser 200, and the Access PPO with Kaiser, you are either an individual or you're a family, whichever benefits you more. So for example, if you're on that Kaiser 200, it's a $200 per person deductible. So if I as an individual go in and I meet my $200 deductible, the plan will pay at the normal rates for me. Then if my spouse goes in and he meets his deductible, the plan will pay at the normal rates for him. So on the Kaiser side of things, On the 200, it caps at the deductible amount for only 2 people. On that flip side, the Health First 250, so that comparable plan, caps at the amount for 3 people. So again, it's either an individual or a family, whichever works best for you, but that cap is a little bit higher. And then also on the Access PPO, it's a 3-person cap. Mm-hmm.
And is it for the Health First?
Correct. So the question was, if there's just 2 individuals on the plan, is it still that family level? Yeah. Yes. No, any 2. Yep, any 2. So if you are on that Health First 250 or the Access PPO where there's a 3-person cap, if you only have 2 people, you only pay that amount for 2. So you would pay the 250 for the first person and the 250 for the second person, and then you're done. So that cap for you would be 500.
So what is there a value then to out of pocket?
Mm-hmm.
So probably $250.
And there's also some, you'll see.
That's what I'm trying to understand. Like, I just be telling the doctor don't cover me.
So you'll actually see that there's some bells and whistles kind of built into those deductibles for the basic plans. So I'm going to ask you to hold your question until the next couple of slides, and then we'll come back to it. It's 3, so 3 or more on the, yeah, it depends which plan. Mm-hmm. If one individual has a very expensive bill, they would only meet the deductible for themselves, and then the plan would pay at the normal rates for them. So essentially, you wouldn't have to meet that family level deductible. The plan would pay at the normal rate for that high user. And then if someone else later got sick, they would need to meet the deductible individually, or any combination. Say you're covering 8 household members, any combination of the $750 or $400, depending on which plan you're on, would meet that deductible. Does that make sense? Okay, so let's rewind. So if you just have one person using the services more heavily, they meet their deductible for themselves as an individual separately from the family, because in that scenario, that's what's going to benefit you the most. So you'll only pay the $200 or the $250, depending on which plan you're on, for that individual, and then the plan will pay at the normal rates, rather than paying the $750 out of pocket and then paying at the normal rates. Does that make sense? So we do that to benefit you more. So essentially it lowers your out-of-pocket cost if we break it down between individual versus family, unlike the high deductible health plans. So on that high... Okay.
So, I see what you're saying. So if you had a family of 5, all you have to do is get to 7.
Correct. Yep.
Versus $250 for each one of the 7.
Correct. So it caps at that 2 or 3 person amount. Yeah. So no. Some plans work like this. Your current plan has no the $10 copay plans. Yeah, there are still out-of-pocket maximums on these. These are not them. So these are kind of upfront costs. You'll see the out-of-pocket maxes soon. Either per person or per family, yes, it does. And again, that's, I would say, not the norm. So on most plans that are out there, you do have to meet those family level numbers if you're covering more than just yourself. We've designed these this way to kind of minimize that cost sharing, hopefully, so that it's more of a benefit to you. So it's either you're an individual or a family, whichever shakes out better for you.
So you go out, you start out at county or not necessarily knowing?
I mean, pretty much. So essentially the accumulators just go. And if you do hit that individual deductible for either you or your child or your spouse, whoever is the one seeking services, the plan will pay at the normal rates for them, and that's what's most beneficial to you. And then if others are using the services and they hit their deductibles and at some point you hit the cap, then it pays at the normal rates for everyone. So it's all kind of behind the scenes. You don't really have to pay attention to anything.
Can I just say that we're recording this and it might.
Any other questions? So on this piece, I really just wanted to highlight that high deductible is the exception. So the high deductible, you always have to meet that family rate if before the plan will pay at the normal rates. So the other plans do have some bells and whistles. So here you'll see a little table that should be pretty illustrative. So on all of the plans, preventative care is not subject to the deductible or coinsurance. That's not exclusive to the AWC trust plans. That's the law under the Affordable Care Act. So preventative care is always covered at 100% as long as you go to an in-network provider. On those high deductible health plans that we talked about, the only thing that's not subject to the deductible is a specific list of medications that come with each carrier. So these are generally generic, preventative, maintenance type of medications. Those you'll just pay at the normal rate. Everything else is going to be subject to the deductible. So on the high deductible health plans, if you go to an office visit, that's typically, we like to ballpark it at $125 on average. You would pay that $125 up front until you meet your deductible on that high deductible health plan. These other plans, so the Health First 250 and the Kaiser 200 specifically, have some other things built in to kind of slow down meeting that deductible. So this is where your question comes back up. So on both of these plans, the first 4 office visits per person per year are not subject to the deductible. So you'll just pay the normal rates for those first 4 office visits for all of them. So again, if you do have a child that maybe goes twice a year, those are not going to be subject to the deductible, so you won't pay for those. Prescriptions on these plans are also not subject to the deductible. You'll just pay the normal copay amounts for those. There is a 4th quarter carryover on these plans. So essentially, if you go all the way till the 4th quarter of the year, so October, November, December, and you haven't met your deductible yet, any charges that are applied toward the deductible during that time period will carry over for the following year. So again, we don't want you to hold off on seeking services if you get sick in, let's say, December because you know that your deductible is resetting in January. We want you to go before it becomes a bigger issue. And then on the Kaiser plan, the 200, there's an extra little bonus. So the first $500 in labs are covered at 100%. So on the Regent side of things, this is very possibly an area where you would meet your deductible. So for example, if you go to the doctor, it's your first 4 office visits, you have a sore throat, and they say, oh, we think it might be strep throat. They're going to run a test for that, and that would be a lab, and that would be subject to the deductible on the Regents plans. I had that test a couple of years ago. It was $125, so that would be applied toward your deductible, and you're halfway there as an individual in just that one test. But you wouldn't be paying for the office visit. Does that make sense? So on the Kaiser side, you would get that lab for free up to that first $500. Any questions on any of these kind of caveats to the deductible charges? Yes.
So, preventative care, if you go to the doctor for a physical and he says, I want to take blood work in order to see
Mm-hmm.
whatever you're at. That lab subject to it, or is it because of the care?
So it would depend. Okay, so the question is, if you were on one of those first 4 office visits, your annual physical, and your doctor determines they want to do...
Preventative care, not subject to it. So if you're going in for a well visit,
Right.
physical, and they say, I want to take a blood test to see if that's how much it's calming.
Right.
When you go in for a physical every year,
Mm-hmm.
are you going to get charged for lab work, or is that covered under preventative care?
Okay, so again, the question is, let me rephrase it. If you're going for a preventative care visit, so your annual physical or something like that, and the doctor determines that you need some blood work, either for high cholesterol, you're going in for your PAP, you're going in for all that normal kind of preventative stuff, is it going to be considered preventative or is it going to be considered a lab? The answer to that is it depends on how they code it. So if they code it as preventative, and we'll get more into preventative services later in the presentation, you just jumping ahead of me every time. But essentially, it is in how the doctor bills it. In many cases, it could be preventative. In some cases, it could be charged as a lab. So we'll get more into that. So copays, coinsurance, and out-of-pocket maximums. So this next page is really kind of the big takeaway from today. So those $10 copays are going to go away. Now you are going to have a coinsurance. So remember, this is a flat rate as opposed to a percentage rate. You'll now have the percentage rate, so you will start to understand and get better visibility into what those actual services that you're using cost. So on the Regent side of things, the Health First 250 covers generally 90%, and you'll have a 10% coinsurance. So no more flat copay amount, just the 10% coinsurance. On the high deductible health plan with Regents, it covers 80%, so you would be left with the 20% coinsurance. On the Kaiser side of things, you will still have a copay, so it's going to go from, on the 200 and the high deductible health plan, you'll have a $20 copay, so that flat amount visit, and then on top of that, you're going to have a 10% or 20% coinsurance, depending on which plan. And actually, all of these that are up here today all have just a 10% coinsurance. So again, it would be, say your office visit costs $125. As I mentioned, it's kind of a ballpark. So on the Regent side of things, you'll pay 10% if you're on that Health First 250. So 10% of that would be $12.50. If you're on the Kaiser 200, it would be a $20 copay, and then 10% of the remaining balance after that, which I think is $10.50. Right? Okay. So roughly you would be paying $30.50 compared to $12.50. However, those Kaiser premiums are typically lower. So that's kind of where that trade-off occurs, is with these more basic services. On the Access PPO, you actually get a little bit of a better deal. If you're seeing a primary care physician, it's still going to be a flat $10 copay or a $20 copay if you're seeing a specialist. And you'll see also that there are these enhanced rates. These are if you use a group health facility or a group health or Kaiser facility. On this plan, as I mentioned, you do have access to the First Choice Health Network, so you can access a lot of other doctors, but if you keep it in-house and go to those Kaiser facilities, you'll get those lower copay rates. And then again, you'll still have that 10% coinsurance on whatever the difference is. Any questions here? So copays and coinsurances are not applied toward your deductible because it indicates that the plan is already paying at the normal rates. Where they are applied, though, is the out-of-pocket maximums that we were talking about just a little bit ago. So you'll see here that the out-of-pocket maximum from the Health First to the Health First 250 does jump up pretty significantly. So from $1,100 for an individual to $3,000 for an individual, or $2,200 for a family to $6,000 for a family. The high deductible plan is $5,000 for an individual or $10,000 for a family. On the Kaiser side, there's not as extreme of a jump because that $10 copay out-of-pocket maximum is already kind of up there. So on the Kaiser 200, it jumps up to $2,500 for an individual or $5,000 for a family. The high deductible health plan is lower on that Kaiser side, so $3,750 is the individual cap or $7,500 for a family. And then on that Kaiser Access PPO, it's $2,500 or $5,000. So again, this works the same way as those deductibles on those core traditional plans. It's either as an individual or a family, whichever benefits you the most. So if you as an individual have that one child who spends $1,000, say that they actually spend $3,000 or whatever plan you're on's cap is, the plan would then pay it 100% for them for the rest of the year. So if they had, let's say, a serious surgery in March, they were hospitalized for a couple of weeks, they hit that out-of-pocket maximum, then later in the year they need another surgery, that's going to be covered at 100%. They're not going to pay copays for medications. No more copay or 10% coinsurance if they're going to the doctor. Everything that would have been covered before is now covered in full. If you have any combination of those family members, so as you'll see, all of these caps are just for 2 people. So if you have 2 people that would have hit their out-of-pocket maximum, or any combination between you and your 4 or 8 family members hit that family level, the plan will pay it 100% for everyone. So again, this is kind of intended to be your safety net. This is your absolute worst case scenario, maximum financial exposure should something unexpected happen or if you have a serious chronic illness in your family. Any questions on these? And then just to reiterate, the amount of people who hit that out-of-pocket maximum is very, 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 very low. So on that Health First 250 last year, it was less than 4% of people actually hit that family level. On the Health First 250, which is much lower than anything else, it was still less than 10%. So we want you to be prepared if it is you. It's going to be someone, but we don't want you all walking out of this room thinking you're hitting the out-of-pocket maximum next year. Any questions? So this next slide I won't spend much time on, but this is just essentially an example of how the coinsurance works, that mathematical breakdown. So essentially, if you're on a plan that covers 90%, it's going to cover 90% of the charges and leave you with the 10%. This is just kind of a breakdown and showing you that it's not a total situation that will break the bank for those normal services. So now we'll get into kind of what some of those services actually are. So we've already talked a lot about the doctor's office visit, so I'll kind of skip over that one. But you will see some changes here as far as labs, x-rays, and other diagnostic tools. So there's two areas on these plans that currently pay at 100% that going on the $10 copay options that no longer will be covered at 100% on the remaining 2018 plans. So one of those is right here, the labs, x-rays, and other diagnostic tests. So currently on those $10 copays, it's paid at 100%, so you're not paying anything for labs. So now you will. You'll pay that standard 90% or 80% on the Regents High Deductible, with the exception of Kaiser, where I mentioned on that Kaiser 200, you do get those first $500 in labs for free. Phone and video consultations, so this is one difference between Regents and Kaiser. At the beginning of this year, we did add to our other Regents plans, and we didn't add it to the $10 copay because we didn't want to enhance it just to continue taking it away. But Regents has partnered with a vendor called MD Live, and they offer a service called telehealth. So what this is you can essentially download an app on your smartphone, or if you have a webcam access from your laptop or a desktop computer, you can actually video conference with a physician 24 hours a day, 365 days a year from the convenience of your couch when you don't feel good or when you have a sick child at home. And that is still just a $10 copay on that Health First 250, or it's $38 on the high deductible health plan until you satisfy that deductible. But as I mentioned, we rolled this out at the beginning of this year, and so far we're getting really great feedback on it. So it's not going to be your physician, but it will be a physician. And they can typically diagnose and write a prescription for many common ailments. So they can't solve all of your problems, but things like sinus infections, flu, lots and lots, long list of items that they're happy to diagnose. If you have a broken arm, probably not the telehealth. But for most things, they can diagnose you. So if you have, say you get sinus infections frequently, you kind of know if you have one. So typically that is something that they can take care of for you. And again, just write a prescription without you having to leave the home. Kaiser doesn't offer anything similar to that, but you can secure email your actual medical team at any time. And then preventative care, we're jumping in here. So essentially, as I've mentioned a couple times, preventative care is always covered at 100% under the Affordable Care Act as long as you go to a participating provider. So for example, the thing to keep in mind really with preventative care is what's preventative for one person may not be preventative for someone else. So a flu shot, for example, is pretty much preventative for anyone. As long as you go to a preferred provider, that's going to be covered at 100%. A shingles vaccine, on the other hand, is considered preventative typically if you're age 60 or older. If you're 59 and you get a shingles vaccine, you're probably going to pay for that. Same thing with something like an osteoporosis screening. Again, it's typically age 60 or older where that's considered preventative and will be covered in full. But there are exceptions to this. So for example, if you have a lot of colon cancer in your family, typically colonoscopies are not considered preventative until age 50 and older. Say you're 35 and you have this family history, your doctor may determine that that's preventative for you, and that's how they would code it, and then it would be covered at 100%. So again, it's all in how they code it. which the carrier nor we have any control over, but you can always ask your doctor, and they may be able to tell you, or they may kick that question back to their own billing team to confirm. And then one thing we do like to advise is if you are going for that annual physical or something like that, they're typically always going to ask you, is there anything else you want to talk about today? And if you start talking about your elbow pain or your migraines or whatever the case may be, your doctor is at that point no longer administering preventative services. And if they wanted to bill it as a normal office visit instead, they are definitely within their ability to do so. So the hope is that that would just be applied as one of those first 4 office visits, and you'd have a pretty minimal cost anyway, but we just want that expectation to be set that it may not be covered at 100% if you do go off script. Any questions on preventative care? So in the hospital, and of course this is where many of those charges can add up very quickly. So for the facility, on the current $10 copay plan, so on the Regents side, you have a $150 copay, and then it's covered at 90%. So on the other plans, that big copay actually goes away, and it's just covered at the 90 or 80%, depending on which plan. On the Kaiser side, on the $10 copay, you have a $100 copay per day, up to 4 days or $400. So again, that just goes to the standard 90% on all of the plans. For outpatient services, no change on the Regent side from the Health First to the Health First 250, still covered at 90% or 80 on the high deductible. On the Kaiser side, outpatient services, so again, this is something like if you have an x-ray in a hospital setting, if you have an outpatient surgery, something like that, this is currently a $10 copay for you. So I think we can all agree that $10 is not representative of the cost of an outpatient surgery. So this is getting more in line, and as always on that Kaiser side, you're going to have that $20 copay, and then it's covered at 90%. For the emergency room, again, you'll see some littler changes here, but you're typically going to have a copay, so $75 to $150, depending on which plan you're on, and then it's covered at the 90 or 80%. If you do have that copay and you are admitted to the hospital, the copay is actually waived, so essentially rewarding you that you did go to the emergency room when you had a true emergency. The other area that I mentioned, there were 2 that are currently covered at 100% and will not be anymore, so this is the other one. So when you're hospitalized and you are seen by a million doctors, you're currently only paying for the facility. You're not paying for the doctors who are actually treating you. So now you will. You'll be paying that standard 90 or 80% for all of the physicians, anesthesiologists, surgeons, internal medicine doctors, anyone that's servicing you while you're in the hospital, you will see the bill for those as well. Any questions on these? So I know that it seems like these could add up, but just remember they can only add up to those out-of-pocket maximum numbers. So they can only add up so far. Okay. So then maternity services, not huge changes here. So office visits for maternity are going to pay like a normal office visit. Hospitalizations for maternity are going to pay like a normal hospitalization. The big thing to keep in mind, and this is not a change, but it's something that we do like to remind you of when we're out here. So under the ACA, you can keep dependents on your plan up until age 26. There are a lot of childbearing years in that window. So if you have an adult child who's on your medical plan who gets pregnant, on Regents, that is not considered a covered service. So what that means is not only will you be on the hook for the bill, but it will also not accumulate toward that out-of-pocket maximum because it's not a covered service. Kaiser does cover adult dependents for maternity services. Bless you. So that is a consideration if you do have adult daughters who are in that childbearing age. We are looking at potentially changing this for 2018, but at this time we're not sure. So again, just one thing to note on the Regents versus Kaiser shakeout. So then rehabilitative therapy and spinal manipulations. So on our plans, we pool the rehabilitative therapy services. So this is a combination of massage, physical therapy, things like that. On the Regents side of things, there's no change in the visits from Health First to the Health First 250. So you still get 99 visits covered at 90%. On the high deductible, you get 25, which is much more normal as far as what's out there in the marketplace, and those are covered at 80%. And then on the Kaiser side, typically all of the limited item visits are a little lower than on those Regents plans. So on all of the Kaiser options, it's 60 visits, and it's going to be that $20 copay, and then the 10% coinsurance after that. One thing to keep in mind is that for massage and physical therapy, so the things that are covered here, this is one of the few areas that on both carriers, it does require a prescription. So we like to reiterate that, especially on the Regents side. Some people anecdotally have told us, oh, I got a prescription 10 years ago and they've never asked again, and I'm getting so many massages and I'm loving life. You can do that, but just know that you're gambling, because at any time Regents could catch on and back bill you and try to recoup those funds for massages that you got without a prescription. And with $99 per year, you could get into trouble very quickly. So just know that we're not going to tell on you, but you are gambling if you are doing that. So it's a good idea to just make sure that those prescriptions are active. Neurodevelopmental therapy is separate, and those are listed below. And then spinal manipulations, no change on the amount on the Regent side, so you still get 15, or you get 10 on the Kaiser side, or 8 on that Access PPO. The thing to keep in mind is currently, especially on that Regents plan, you're only paying the $10 copay for that initial visit, and then after that, the next 14 spinal manipulations are covered at 100%. So now you'll be paying that 10% coinsurance each time you go. So again, kind of building in that double check of, am I going because it's helping me, or am I going because it's free? So again, those shouldn't be expensive, maybe like $5 per visit, but 5 times 14, it does add up. Any questions on these? So then medications. The big thing to highlight here on the Regent side, so generics are going up by $1, so $4 to $5 on that Health First 250. Generic meds make up about 85% of the prescriptions that are written in our pool, so the huge majority of our medications are generics. But for those that aren't, you'll see that those name brand formularies go from 15 to 25, and then the non-formularies go from 35 to 50. And Regents has now scaled for specialty medications. So specialty meds are thousands or tens of thousands of dollars per year. These will cost you a $100 copay now on the Regent side. It is only 1% of the prescription drugs that are written in our pool, so it is a very small amount. But that 1% makes up about 36% of the total cost of all of our medications. So like I said, they're very, very expensive. They're not only for rare diseases. They make specialty medications for arthritis or things that are very common. So our recommendation is, if you are on a drug now that's $35, that you check our specialty medication list to see if it is something that you should expect to pay that higher rate for. On that high deductible side of the Regents plan, you'll notice that all of the medications will cost you a 20% coinsurance. So again, a 20% cost of what that drug is. So you'll now know how much they cost. So those specialty meds, for example, if you're on one of those, let's say it costs $1,000 a month, you would pay 20% of that, so $200 a month. Keep in mind that as long as it's a covered drug, it's going to accumulate toward that out-of-pocket maximum, but something to keep in mind. On the Kaiser side, currently all of the medications on that the Kaiser $10 copay plan are only $10. So now the generics, which like I said are the vast majority of the drugs, are still going to be 10, but then they've also tiered out as well. So some drugs will be 20 and some will be 40. Kaiser has not on any of the plans scaled for specialty meds, so the most you would pay on any of these is $70. So a little bit of a potential cost saving there. And then on both carriers, you do have access to a mail order pharmacy. So that is a 2 copays for a 3-month supply for most drugs. But just keep in mind that not all drugs are available through mail order, and typically the specialty medications will not be available. So the question is, on Health First 250, would you ever pay more than $100 for a drug? And the answer is no, as long as it's a covered medication. So there are definitely drugs that are not covered on Regents or are not covered on Kaiser or are not covered on either. So it is important to make sure you're using a covered drug. Regents has a very extensive formulary where they can offer substitutions if you're on something that's not covered, but things are added and dropped from their list of covered drugs all the time. So if you're on something that's not covered, or if you're on something that is covered but they're taking it away, they'll actually send you a letter and say, hey, we're removing your medication, but here's these 3 others that we think would work for you too. But again, it's all up to your doctor what they want to prescribe you. So if they're prescribing you something that's not covered, that might be one of those situations where if you do have double coverage, it might be worthwhile if that secondary plan covered the medication. Any other questions here? So then the other key differences, kind of when you're making that choice between going with Regents or going with Kaiser, these are some things to keep in mind as well. So worldwide care, Regents utilizes the Blue Shield network, which is essentially everywhere you want to be. So if you are anywhere within the U.S., on a remote island, on vacation in Italy, if you would like to see a doctor, there is very likely a Blue Shield provider that will treat you as in-network wherever you are. For Kaiser, if you're outside of that Kaiser service area, which is essentially Washington, Oregon, most of California, some of Idaho, Alaska, and I've heard Hawaii, but I've not confirmed that. If you're outside of that, they will only cover you if it's an emergency or an urgent situation. So for example, if you have an adult dependent on your plan who's going to school in Texas, they are not going to find a provider that's in network for them in that area. So that's something to keep in mind. Orthotic devices are covered on Regents, but not covered on Kaiser, so the special shoes or the special shoe inserts. Naturopaths are covered on Regents at the same rate as a regular MD. On the Kaiser side, you have 3 self-referred visits per diagnosis to a naturopath, and then after that, you do have to jump through some hoops in order to get additional visits approved. And then acupuncture, you get 12 visits on the Health First 250 and 8 on the Kaiser side, so a little bit less. But they are both covered at that standard 90% rate, and Kaiser has that $20 copay. So then the last slide is just our contact information. So you can always call Regents or you can always call Kaiser, but you can absolutely call us at the Trust. We're there to answer your questions. We're there to advocate for you on your behalf. If you received a bill that you thought was incorrect, or if you are curious of if a service is going to be covered, absolutely reach out to us and we're happy to look into that for you. Yep. If it's inpatient, it's going to pay like an inpatient rate, so, and just the standard 90 or 80%, depending on which plan. And outpatient is going to be the standard outpatient rate, so that 90 or 80% with the copay. Yep. Yeah. Nope. Any other questions? Yeah. How do you go about the phone and video consultation? So all you do is you download the app, so it's called MD Live, from the App Store. And again, it's not on the $10 copay plan currently. It's only on the other Regents options. But you just download the app, and then it'll just prompt you to, you want to set it up before you're sick, because the last thing you want to do is like create an account when you're grumpy and not feeling good. But it will ask for your Regents ID number and your first name, last name, that type of stuff. So you just set up an account, and you will have to put in a card to pay your copay amount, your $10 copay. But once you set up the account, you're all set, and you just dial it in. What we've heard so far is that there's no wait. They get right through to a doctor right away. We've got really great feedback on it so far. No, your Regents ID number. It does not. The video chat is separate from those first 4 office visits. I'm sorry, what? Yes, you pay a copay. So it's not subject to deductible, except on that high deductible health plan it is. So it's $38 on that high deductible option. Not on the $10 copay plan, no. Hi. Mm-hmm. Typically, yes. So the question is, if you're seeing a naturopath on the Kaiser network, how do you go about finding one? So it depends on where you're at. So some of those facilities do have naturopaths in-house, but many contract outside. So Kaiser does sometimes contract with doctors that are outside of their in-house facility, and that would likely be the case with a naturopath, but they will absolutely give you a list of doctors that it would be covered, naturopath.